Welcome to everyone to our webinar on COVID-19 reflections and the path to recovery.
Now, with our final speaker, who's Helen Boucher. Helen is well known actually in Massachusetts and around the United States as any other speaker that we have today. She is the Chief of Division of Geographic Medicine and Infectious Disease and Director of Stuart Levy Center for Integrated Management of Antimicrobial Resistance at Tufts University, and she's a full professor at Tufts University. She is also the Director of Tufts Medical Center's Heart Transplant and VAD Device Infectious Program. She has a numerous abstract chapters and peer review articles were published in the New England Journal of Medicine, Annals of Medicine, and so on. Also, Helen is set on the Board of Trustee of the Physicians of Tufts Medical Center. I have to say one thing, just I discovered that Helen is also my neighbor. So that's that's important to me. So thank you so much, Helen, if you could start your talk. You're muted, Helen. Can you unmute, please?
The number one job is to unmute. Thank you so much for the very kind introduction, and I'm really honored to be here with you today to talk about therapeutic options. And we're not going to talk about everything, of course, due to time. Let's see here. My disclosures are shown here. I thought we would start with a case that might illustrate how we think about treatment in COVID. So this is a 57-year-old man with hypertension, hyperlipidemia, and obesity who presented with shortness of breath and a cough. In August, a week prior to coming to us, he was at a party and in contact with 2 people who tested positive for SARS-CoV-2. And over the 2 days before he presented, he had progressive shortness of breath, a dry cough, fever, fatigue, and mild diarrhea. On evaluation, he had a high fever. He had some tachycardia, lowish blood pressure, and was tachypnic with an oxygen saturation of 91% on room air. This is his chest x-ray. Pretty common for what we see in COVID patients, these sort of bilateral interstitial infiltrates. He had a low white blood cell count and lymphopenia. His platelets were normal. His other hemoglobin hematocrit were normal. Liver function, kidney function normal. And his sort of markers for COVID, inflammatory markers, including ferritin, C-reactive protein, and D-dimer were elevated. And a PCR for SARS-CoV-2 was positive. Blood cultures were obtained. So the question for us is, what do we do now? And I think, we can call a friend. This is my group. Just want to show you our group here at Tufts, and all appropriately socially distanced for our fellow graduation last year. So first and foremost, if our patient is at home, we're going to manage them supportively. So it's really important to give advice about warning signs for things getting worse. Treat it like any other respiratory virus with fluids, rest, acetaminophen, but patients need to be advised to call us if they're developing shortness of breath, they're unable to keep themselves hydrated, and there should be a good plan for how to obtain medical care safely. How will they get to medical care here in the United States? We ask people to call us, and then we put a plan together to make sure that the healthcare providers know that someone's coming in who may have COVID. When a patient comes to the hospital, our supportive care depends on the severity of illness, and as we heard earlier, our ability to provide the supportive care has improved largely thanks to our critical care colleagues. We use oxygen supplementation in various ways that I won't go into, but that has evolved tremendously since the start of the epidemic. Fluid and electrolyte management and very aggressive care for septic physiology, acetaminophen for fever. We prophylax for thrombosis, and I won't get into that here, but that is a big part of the therapy of COVID patients. And very important to develop and have good policies for managing things like cardiac arrest in the setting of COVID. And that was touched on briefly earlier, but something as you think about your ICU planning, we heard about the intubation team. That's part of a code team and something to really think about because those delays early on probably cost lives. And then ECMO and other support is used rarely in treating COVID. So what about therapies? And this is, I know, a focus of great interest for all of us. And the good news today on October 31st is that we have two medical therapies that are approved or authorized to be used in treating COVID. One is the drug remdesivir that we'll talk about that is now FDA approved in the United States, and then dexamethasone, an old drug that has been shown to have a mortality benefit. There are lots of other therapies that are being used investigationally, and we'll talk about a few, but due to time, we won't talk about all. So I wanted to give you a couple of resources that might be helpful, that certainly have been helpful to me. So the Infectious Disease Society of America and the CDC here in the United States have partnered to form what we call a real-time learning network, and I put the URL here. We have treatment guidelines and lots of other detailed information about things like infection prevention, dealing with special populations, what's the latest on vaccines, for example, that are all available in a pretty easy to navigate website. This is a look at the treatment guidelines, and you can see that we sort of have drugs like corticosteroids and remdesivir in the middle, and then other things, including updates on early therapeutics under investigation. Similarly, the NIH has treatment guidelines that are published and available on a living website. This is also updated regularly in a very nice resource. The NIH has provided this nice, I think, schematic of how to think about disease severity in our COVID patients. So starting with our patients at home or those in the hospital sort of mildly ill, not requiring oxygen supplementation. I would say that honestly, in my hospital, you really don't get admitted unless you need oxygen supplementation, but in some places you might. That's a setting where care is largely supportive. And then as patients get sicker, we have other recommendations that we'll talk more about. So in terms of antiviral therapies, there are a number of sort of flavors of antiviral therapy. So on the right, you see antiviral medications, and we'll talk about remdesivir, which actually impacts the ability of the virus to multiply. So it has a direct antiviral effect. Other therapies we use are things like antibodies, and the idea there is we're giving the patient immunity by either delivering plasma from people who've recovered from COVID or antibodies that have been engineered to neutralize the virus, and we'll talk some more about both. So first we'll talk about remdesivir, and the structure is shown here at the lower right. It's a nucleoside analog inhibitor of the RNA-directed RNA polymerase of the virus. It needs to be phosphorylated in the cell, and interestingly, this is a repurposed drug. So it failed in trials for Ebola several years ago, and this is a sort of a kind of a plug, I guess, for pandemic preparedness and the need to be thinking about the threats that we know about and the ones we don't know about, right? So we had Ebola, we didn't know about COVID, but the work and the science that was done there is actually helping us in COVID. And so as we learn from this epidemic, I think thinking about having a pipeline and a scientific process that is supported to allow us to develop medicines going forward is really, really important. So back to remdesivir, it's active in animal models for MERS, SARS, and then was studied here for COVID. So we have several studies that we'll talk about that led to the FDA, what is now an FDA approval for this drug. So the first is the ACT-1 trial. This was led by the NIH, and it compared remdesivir to placebo. And we initially learned from an interim analysis that was pre-planned and executed totally according to plan that remdesivir was associated with a shorter time to recovery than placebo, an average of 11 days in those treated with remdesivir compared to 15 for placebo. There was a numeric difference in mortality rate, but it did not achieve statistical significance. And this is important. This has become the subject of much discussion. So here's the final analysis of the ACT-1 trial that was recently published in the New England Journal, and it shows the same message, that remdesivir therapy, when given to people with severe COVID, led to a shorter duration of illness, a faster time to recovery. There were some other trials supported by the company Gilead. This is one called the SIMPLE trial that looked at not remdesivir versus placebo, but two different regimens of remdesivir, a shorter 5-day course versus a longer 10-day course. And in this trial, looking at day 14, there was no significant difference between the 5-day and the 10-day course. Most recently, the WHO Solidarity trial was published and got a lot of press, and I'm sure many of you have heard about it. And this is still in a preprint form. So this is a figure taken off the article on the preprint server that shows that in this trial, remdesivir was not associated with a mortality benefit. And there's been a lot of discussion about whether this is a failed trial, whether remdesivir works or not. And so I thought we should compare perhaps the data between the two trials. And my colleague Francisco Marti here in Boston made this nice table that came to me via Twitter, which is a very interesting way to get medical information, that compares Act 1 versus the Solidarity trial. And there's a couple of key points for us to think about. So Act 1 was a randomized, double-blind, placebo-controlled trial. And in that trial, there was a very clear diagnostic definition of COVID. There had to be a test, a PCR test, and it included patients on any oxygen supplementation. On the other hand, Solidarity is an open label trial, more of a pragmatic trial. And the definition of COVID was not as clear, at least by reading the preprint paper, and was stratified by ventilator status. And the outcome, importantly, of Solidarity was inpatient, in-hospital mortality. So there were some issues where it wasn't quite so clear what happened to patients who got sent home because they were more sick and or put onto palliative care. And there was an observation of overall lower mortality that may impact what we saw in Solidarity. So not quite an apples to apples comparison, and many people have hypothesized that benefits weren't seen in Solidarity because of the population under study. Of course, that is debatable, and I think the sort of bottom line for remdesivir is that most of us are convinced that it helps you get better faster, but maybe not quite sure on which population is the best suited for this medicine yet. So currently, we know this is a drug that's active when there's still active viral replication. It's indicated in the FDA package insert for people with an oxygen saturation below 94% on room air, or those who require oxygen. A couple things to know about this drug are that it can't be used or shouldn't be used in patients who have renal dysfunction with a creatinine clearance below 30. And we have to be careful in liver dysfunction. It needs to be discontinued if ALT gets above 5 times the upper limit of normal. So that needs to be monitored carefully. The drug hasn't yet been approved for use in children or pregnant ladies. There is a compassionate use program available in the United States. And there's an outpatient study underway here, and we're participating at Tufts, looking at 3 days of therapy in outpatients. So taking this notion of whether earlier therapy, earlier intervention in the virus itself might be better. Of course, we don't know that yet, but it'll be interesting to see. So just a little detail on administration. This drug has a loading dose on the first day of 200 milligrams, and then we give 100 milligrams per day thereafter intravenously. 5-day course is appropriate for most patients on supplemental oxygen, but the recommendations from the FDA allow for 10 days duration in critically ill patients or those who require mechanical ventilation. I think there's a lot of discussion in the community about whether that's actually needed and appropriate, and maybe if there's questions, we could talk about it. As we mentioned, monitoring kidney and liver function is important during therapy. Okay, let's talk about steroids, our old friends. And this is a drug that has been available for many, many years. It costs $1 a day, so very, very inexpensive drug, but a lot of conflicting information about steroids and respiratory viral infections. And this is a nice study from the Lancet earlier this year. It kind of summarizes some key data from using steroids in other respiratory viruses. So in MERS, steroids were associated with a delayed clearance of viral RNA from the respiratory tract, exactly what we don't want. In SARS, there was delayed clearance of virus from blood. Again, not really what we want to see. Steroids cause complications, and this is really important to know. They cause elevated blood sugar, mental status changes, even psychosis, lots of other interactions that caused our patients difficulty. So not to be used without some safety considerations. In influenza, steroids have been associated with increased mortality. In an RSV infection, no benefit of steroids was seen in children. So at the beginning of the epidemic, we were all somewhat cautious, I think, in thinking about steroids. Thankfully, we have data to help inform us. And so this is a study from Wuhan that was published in JAMA Internal Medicine back in March. It was one of the early studies looking at 201 patients who had confirmed COVID pneumonia. And in this study, there was a benefit in survival with methylprednisolone therapy. The study that sort of set the stake in the guidelines for advising for dexamethasone is this study, the recovery study that was published in the New England Journal back in July. And this is kind of the key table from that study. This was a study of dexamethasone versus usual care. And in patients on mechanical ventilation or those requiring oxygen therapy, dexamethasone was associated with a mortality benefit. So this led to its recommendation in the guidelines from the NIH and the Infectious Disease Society of America. So currently the recommendations include using dexamethasone in patients with COVID who have oxygen saturation below 94% on room air or require oxygen supplementation, and who don't have any absolute or relative contraindications for steroids. And that's important. I've been involved in the care, and I'm sure my colleagues on the panel have too, in patients where they have milder COVID and they do have uncontrolled diabetes or some other significant problem, and that wasn't really considered. So very important to consider that. The benefits of steroids have been observed in people who have longer duration of symptoms. And the dose is shown here at 6 milligrams IV dexamethasone or orally for up to 10 days or until discharge from the hospital. One thing I'll mention that we won't really delve into because of time is that in the setting of steroid use especially, we need to monitor for secondary bacterial and fungal infections. And a lot of us are concerned that we may see more of these in the setting of more widespread steroid use. Okay, we'll pause and do another case. So this is a 36-year-old man who developed a fever at home back in March. And I'm kind of going to set a little timeline here because I think it will help inform our next part of the discussion. So the first day he had fever and called his doc, who prescribed azithromycin for 5 days. On day 5, he was sicker. He developed GI symptoms, diarrhea, abdominal pain, and lost his appetite. Now we recognize are classic for COVID. And on day 9, he presented to the emergency room with a chest x-ray that showed clear pneumonia. And oh, by the way, his father had been diagnosed with COVID 2 days earlier. He was discharged home from the emergency room, still on the azithromycin. They added amoxicillin, but he got sicker. So on day 11, he comes back to the emergency room and is frankly hypoxic and gets admitted, and they added intravenous ceftriaxone. This is a very common timeline of how people present in terms of it's usually day 8 to 12 when people get to that sick enough phase where they're coming to the hospital, that subgroup who get that ill. And he was treated with tocilizumab, an antibody. So unfortunately, this gentleman got sicker, developed hypotension, had to have pressor support, was enrolled in our remdesivir study, and on day 14 was quite ill with a temperature of 39.5, had to be intubated and had purulent sputum. His bronchoscopy culture grew methicillin-resistant Staph aureus, so he had a secondary bacterial infection, antibiotics were adjusted, and after a complicated course that was complicated with some hepatitis, he had a slow recovery, and on day 28 was discharged to rehabilitation. So this was a long ICU course that we saw in, unfortunately, a number of patients in the initial surge. And I just wanted to show this timeline because I think it's really instructive as we think of the course of our patients with COVID, right? 80% don't get sick enough to come to the hospital. Those that do, many will get better and go home, but those that get sicker will do so around day 9, 10, and then later is when we see this development of those secondary infections and hopefully recovery and discharge, but it's late, it's weeks, 3 to 4 weeks usually. So what about these antibodies? So the first is tocilizumab, which is an anti-IL-6 antibody. There are others, and they were used on label and some in studies. And this is a kind of study from recently from the New England Journal on tocilizumab versus placebo in COVID, and it failed. It showed that it did not work, and the guidelines recommend against its use now. There are others. Cerulumab is a study we participated in, and I won't belabor the details here, but like Toci, this study failed. So the anti-IL-6 antibodies in the setting of hospitalized severe COVID do not seem to be effective. And I will point out that a lot of the data we have, I showed you a study on Toci, but for cerulumab, we still just have a press release data. And I think as you look at data for medicines for COVID, it's really important to remember that a lot of what we're seeing is preliminary, and it's important to follow it through to at least publication so we know the strength of the evidence. And that's why those guidelines I showed you, I think, are so important, because they weigh the strength of the evidence. So what about convalescent plasma? This is taking pooled plasma from donors, many of whom are grateful patients who recover from COVID, and administering them back into patients to passively immunize them against COVID. So initially, we participated in the Mayo Clinic group that did a study that led to the authorization for convalescent plasma here in the United States. This was not without controversy, and I'll show you the president announced the authorization on August 23rd, and we at IDSA and others promptly responded, calling for better trials because of limitations of the data we have about convalescent plasma. So we do have a clinical trial. This is from JAMA in June, a trial from China. And in this trial, they looked at several markers for the addition of convalescent plasma to standard treatment, and they did not see any benefit in that setting. Now, this was not a perfect trial, no trial is, but this one had issues that it was prematurely terminated, so it may have been underpowered, but suffice it to say that we really still lack robust data to help us on convalescent plasma. There is a preprint article on the Mayo Clinic group, and there's it's a 3-month description of 2,800 hospitals across the US, over 35,000 patients, more than half in ICUs. And we saw increased mortality if the convalescent plasma was administered early. And if people had higher titers in that plasma, they did better. The problem is it was not even. It was not clear what the titer was in the plasma that was given to patients. So a lot of questions left about convalescent plasma, and the guidelines continue to recommend using it in the context of a clinical trial. So what about engineered monoclonal antibodies? So these are antibodies targeted against the spike protein. We have studies ongoing in inpatients and outpatients. I'll just tell you briefly, there's two sort of strategies for using these drugs. One is in mild to moderate disease in the hospital or outside the hospital, and the other is in prophylaxis to prevent COVID. And these trials are a little bit earlier on, but perhaps to protect first line workers like EMTs or healthcare workers. There are a number of trials shown on the right. Again, I won't belabor it, but you've probably heard about the Regeneron and the Lilly compounds. They're the closest to regulatory action. So the Regeneron trial in non-hospitalized patients, just briefly, has an FDA review ongoing. It's a really interesting all-one trial for phase 1, 2, 3 that's randomized, double-blind, placebo-controlled. It's looking at this sort of cocktail of antibodies versus standard care versus placebo and standard care in 3 arms. So 2 doses of the Regeneron and a placebo in a 1-to-1-to-1 randomization. The interim analysis of the first 275 patients is out in a press release. I'll be very clear. And the press release tells us that the drug rapidly reduced viral load through day 7, and that there was greater benefit in patients who were seronegative, so earlier in disease. But that's all we know, and we know it's under FDA review. So many other therapies that we don't have time to go into. I'll just show you here in tabular form. This is from that IDSA site I showed you earlier. Other monoclonal antibodies, JAK inhibitors, cancer drugs, interferons, statins, back to the sort of ACE2 hypothesis, vitamin D, a lot of things being studied, old and new, for COVID, and lots more for us to learn. So I'll say 2 words about vaccines, although much of this has been already introduced. We have different vectors and different mechanisms being exploited. The Warp Speed project was highlighted. This is Dr. Fauci showing the number of days from the sequencing of a virus to the first human injection. And at the top, you look at SARS back in 2003, it was 20 months, which was very fast at the time. And for SARS-CoV-2, it was 65 days. Unbelievable science. The first patient with the Moderna mRNA vaccine was injected on July 27th, as Dr. Thielman mentioned, and that is the record for the fastest development of a vaccine ever. We have a little bit of data shown here on that vaccine, a preliminary report on 45 adults, that's 45, where they got the 2 injections of vaccine 28 days apart in the 3 doses shown here. And they showed that antibody titers were achieved and that it was reasonably tolerated, but I'll mention there were adverse events in half the subjects, including mild things like fatigue, chills, and that adverse events were more prevalent after the 2nd dose. Fever in the 2nd dose was seen in a number of people, including those at the higher doses. So this is important for us to see, and obviously when the N is 35 or 33,000, we'll have a much better view. So with that, I will say thank you so much for the invitation to be here and show you my inspiration, Dr. Fauci, and be happy to take any questions.
Thank you so much. Thank you so much for this great talk. And